So in the interest of time, let's move to the last speaker of the track. So we have our unit director, Professor Colin Graham. Colin is an active clinical teacher and active clinician seeing cases in our department, but also he used to be the editor-in-chief of the European Journal of Emergency Medicine, and also he was a co-author on the Oxford Handbook of Emergency Medicine. He received two prestigious awards just in the last 2 years. He was elected the Honorary Fellow of the USEM, and also in year 2020, he was awarded the Order of the IFM, demonstrating his extensive and continuous commitment to the specialty of EM in Hong Kong and the significant contributions to IFM. So I'm going to hand the floor to Colin.
Thank you, Kevin. Can you hear me okay?
Yeah,
excellent.
We can.
Good morning, everyone. Again, it's lovely to be here. And again, my huge thanks to Kevin and Junie and Mackie and everyone, Isabella, everyone who's been helping put this together over the last few weeks, but also particularly today. Time is tight, so I'm going to get cracking on this. And really, my intention today is simply to make you all think and to challenge you on where we might be going in this decade. And our excellent speakers this morning so far have been talking to us about where we're going, but also they've reminded us about where we've come from. And I'm also going to do the same briefly, take you back to our origins a few years ago, maybe not in so much detail, but just from my own perspective. And then a few of our challenges and solutions, and to challenge you on where we should be 10 years from now. Now, I'll tell you right at the outset, 10 years from now, I hope I'm staring retirement right down the barrel of a gun and looking forward to a rest. But we'll see if I even get there. But that's another story. But the main thing from my point of view is at that point, I'll be looking at EM from a user's perspective rather than as a provider's perspective. And I think that is a useful perspective to have because ultimately it's our patients that count. So I'll take you back to my own training. It's hard to see the thing at the bottom. This is a picture from 1911, and it's the waiting room at what was then the outpatient casualty department at Glasgow Royal Infirmary. I come from Glasgow in Scotland. And this hall that we're looking at, you can see this old hall here. This was actually the very building that I worked in as a medical student and as a registrar in Glasgow, right up until the early 2000s. This room here where the policemen are fairly standard features in emergency departments, as we'll see in a moment. This room here was our doctor's room in 1997. And where these poor people are sitting here, this had been converted into a clinical area where you saw the patients. And these two rooms at the back here were actually operating theatres in those days, but became our resuscitation rooms in the 80s and the 90s, and indeed right up to 2002. We've come a long way since then. In the UK, this was another very famous figure, a guy called Maurice Ellis. You can see his casualty officer's handbook here. Maurice Ellis was the first emergency department, as we would call it, consultant in the UK. He was appointed in the early 1950s and 1952. You can see on this book, he was defined as the consultant surgeon. Surgeon was the operative word at that time, in charge of the casualty department and receiving room at Leeds General Infirmary. And in fact, just a few years ago, he was honoured with what's called in the UK the blue plaques, which is a way of kind of designating where someone made their impact. And as you can see, he was the first casualty consultant in the UK. And he was the first president of what was called the Casualty Surgeons Association, which went on to become our sister organisation in the UK, the Royal College of Emergency Medicine. Why is any of this important? Well, it's important because we came from a surgical background predominantly, and Hong Kong was no different. Maurice Ellis in Leeds was known by all of his staff as the father. And in fact, in emergency medicine history, we talk about him as the father of emergency care. But in Hong Kong, as Axel has eloquently told us, Queen Mary and Kowloon Hostel were the first casualty departments on either side of the harbour. But predominantly in those days, they dealt with accidents, with trauma, minor trauma, major trauma, poisonings, and the so-called police cases, which were assaults and domestic issues and all sorts of things. The past isn't so far away. At least one person in that picture, which is from Prince of Wales back in the early 1990s, at least one of those people in that picture is still working at the moment, although she probably won't appreciate me saying it. And you can see that we've changed a bit since then. We no longer bother with the caps so much in the pre-hostel situation. We do tend to use things like collars and don't use a pillow for the head injured. And our PPE has improved considerably from just wearing a pair of gloves, especially in our current environment. And how have things changed over those last 20 to 30 years? Well, to summarize, essentially what we've seen until obviously the recent events in Hong Kong, a huge decrease in interpersonal violence. What it used to be back in the 50s, the 60s, the 70s, and even right up to the 90s in Hong Kong has progressively got better as our economy has improved. I was very interested to see Jim Ducharme's comments on the interaction between the economy and healthcare, because this is something, as he rightly said, that has been underappreciated. Our population is progressively long-lived. We have the oldest population in the world now, the highest expectation in terms of years lived, and that has had a massive impact, along with the size of the population, which has gone from less than 1 million at the end of the Second World War to our current more than 7.5 million people in Hong Kong. We've gone from those 2 casualty departments to 17 or 18 A&Es in the public sector, and an increasing number of emergency centres in the private sector too, and that will undoubtedly continue to increase. We've seen, and again, I won't repeat this in detail, but huge improvements in the recognition and training of emergency medicine as a discipline. That has increased the standards of care enormously. Maurice Ellis's Casualty Surgeon's Handbook was the start, but now we've moved on to higher qualifications, to fellowships, to proper specialist training in the discipline. And it's quite sobering to realise that we didn't even have a specialist qualification in our discipline until the 1990s. If you take the FRCSA&E from Edinburgh as a specialist qualification, it isn't really, but it was talked about as such, maybe the 1980s, but we've evolved to a proper specialist qualification only in the 90s. I think the other big thing that's happened, which ties in with the interpersonal issues, is the medicalisation and what I call the geriatrification of emergency medicine. We've gone from a situation where during my training it was 50-50, and I didn't train that long ago. And now, certainly in Hong Kong, 85% of our workload is non-trauma. My ward round last week in the emergency medicine ward, the first 6 patients I saw were all over the age of 85. In many parts of the world, the emergency departments, and particularly short stay units like our EM ward, wouldn't even look after these patients because they're too complex. And that complexity is reflected by the number of investigations we do and the type of investigations we do, and that has changed the specialty beyond recognition. This is one of our, from a few years ago, one of our stroke protocols. When I was training, and again, not that long ago, you put a stroke in a bed and, you left them to do or die. Now we do all this. We have these increasing numbers of patients who need assessed, they need assessed quickly, and they need cross-sectional imaging rapidly. Looking at YY's talk just a few moments ago about pre-hostel care in Singapore, if we look at some countries and some cities like Berlin and Helsinki in Europe, they now have mobile CT scanners, and they'll scan people before they even get to hospital. We may have some progress to do on this if we think this is appropriate for Hong Kong. So what are our current challenges? I think our biggest challenge is the fact that we've done so well in Hong Kong at keeping people alive for a very long time. It's a great thing, but it means that as we get older, our number of comorbidities increases, our number of drugs increase, and our complexity of that illness becomes higher. One of our real challenges is that emergency department staffing has consistently been done on the basis of trauma, and that is no longer reflective of what we see. And none of our current staffing formulae, if you look globally, in any way, shape, or form recognize the complexity, particularly of multi-morbid, multi-comorbid elderly care in any way, shape, or form. We've had a lack of inpatient beds. Efficiency is one thing, but we've gone too far. And some countries, particularly like the United Kingdom and Hong Kong, we run consistently at 105% occupancies, which means when we have a problem like COVID, we just fail to cope. Hong Kong has got better with access block, to be fair, in the last few years, but we're still not there yet. We still consistently run near 100%. And that access block leads to crowding, crowding leads to poor patient flow, long stays, and that is exacerbated by our lack of access to decision-making imaging options. And I know we've got some talks coming later on imaging as well. Our other challenges, COVID-19, I don't need to remind our listeners today about the challenges of COVID-19, which we continue to suffer. But that surveillance and identification of emergency infectious diseases is critical. You'll remember that SARS in 2003, the first person to be infected in terms of healthcare workers was a triage nurse at Kwong Wai. Many countries have an utter lack of pandemic preparedness and poor infection control training. Jim alluded to this, but in fact, Hong Kong, I think, was very well prepared by our experience of SARS in 2003. And the numbers in Hong Kong really demonstrate that just amazingly well. But there is no question that access block and ED crowding are in no way compatible with infection control, and certainly not with viral pandemics. And we've gone back, we've bounced in the last few months straight back to having high numbers of patients who are all jammed together in an emergency department with very little in the way of spacing. This is a problem that we need to address urgently. Other things, and again, I know time is tight, so I'll keep this short. Trauma's changing. We have gone from multiple trauma, high-speed road traffic crashes, certainly in Hong Kong and many other developed countries. Our predominant challenge now is low falls in anticoagulated elderly patients. Mental health is a big issue. Mental health problems have increased because of COVID. And the use of the ED as a safety net is appropriate, but it's often overused because of a lack of primary care provision. Polypharmacy is incredibly important now. I find now I spend a large amount of my time just changing drugs or stopping drugs, actually. And I think it's very proportional to advancing age. And I think as ED has evolved, we now need to be very skilled and knowledgeable pharmacologists, which is something in years past we would never have even considered. The surgical origins of emergency medicine took us a long way, but we now need to be more like physicians. And in that respect, evidence-based emergency care is really very slow to be adopted. We think it takes somewhere between 10 and 13 years for a clinically important change in practice to actually be implemented in the real world. And that is a huge problem. Even if you take one of our studies, which I'm sure you'll see later on the breaks, we showed some years ago a study led by Raymond Zheng and Tim Rayner that steroids were a very good choice for acute gout leading to admission to hospital. I would say at least 50% of the patients who are admitted at the moment continue to not be given steroids because we just don't implement these findings accordingly. So what's not going to change? Well, what's not going to change is we're not going to get any younger. Our population is going to continue to age. The proportion of patients who are older will increase. The number of drugs that they will be on will certainly not go down. It will become more complex. Our imaging capacity is unlikely to improve a lot. We could go out and buy another 10 CT scanners, but we will be highly unlikely to have anyone to interpret the scans. We may have some help with that, as we'll see later, from AI, but it's unlikely to improve considerably. And the staffing, both in emergency departments and in terms of our support systems, is unlikely to radically improve despite efforts to try and do so. So, solutions. We need to think about the phases of care. And traditionally in emergency departments, we've thought about input, throughput, and output. Let's briefly consider these. This is the input. This was our department, our old department, and this was the triage station in the old department. When I first came to Hong Kong in 2004, that was fairly typical at that time, and that was a picture taken just after SARS. So again, our infection control had a lot to be desired even then. But that is the reality of what we're trying to sort out on a busy Monday morning. The questions we need to be asking ourselves: can we divert any patients? Can we get patients to another source of care? There may be specific patients like STEMIs or strokes that don't need to be with us. We know the diagnosis from pre-hospital care, as YY has alluded to, and they could go directly to that source. We know from other countries, the US, the UK, and Australia, that primary care facilities, when they're co-located at the emergency department, don't work out well. That's not a good solution. And despite the evidence to show that, which has been evolving over 20 years, governments continue to think this is a good idea when it's not. One thing that's been talked about in light of COVID to minimize social interactions and maximize social distancing is, should we consider scheduled emergency department appointments? Honestly, when I first heard that proposal, my heart sank and I thought, oh my God, this is the end of the world. Emergencies are supposed to be emergencies, but maybe this is a way of balancing need and demand and provision of care. With throughput, we need to speed things up, but how do we do that without sacrificing patient care quality? We've known for years that standardized investigation package orders at triage help speed things up. If you have a stroke, you get a set list of investigations. If you have gout, if you have a fractured hip, but those orders need to be done right at the front door to make a difference. We know from other studies that admission teams and discharge teams and screening patients who are likely to fall into one category or another can also speed flow. And we can minimize specialty reviews of ED patients by just admitting them when they need to be, because we know that adds little in the way of value. We need more senior staff who need to be involved in the care of every patient so that we get this right at the start. And in terms of output, prompt admission to the right wards, the right patient, to the right specialty at the earliest opportunity. We have to improve access to very early outpatient care. We often admit people to the wards because we know they can't be seen in an outpatient clinic until 6 or 8 weeks have passed. That's not very early. Very early is tomorrow. We need better discharge planning. That's not our realm, but we need to work with our colleagues upstairs in the wards to make sure that happens. And we need to work with our friends in the community to make sure that patients are offloaded at the other end. And that, given our population change, also involves access to the frail elderly assessment and support services, which again is woefully inadequate. This is the reality of an emergency department like the one we work in on a busy morning. Not a lot of social distancing here, but a lot of patients who need care. So where do we need to be in 2031 just to wrap this up? We need to improve our primary care provision, first and foremost, so that fewer people come to the ED for primary care issues like diabetes and hypertension. We need to massively improve our ability to diagnose and differentiate infectious respiratory disease. And we need to learn about frailty assessment. That is going to be our bread and butter. Our trauma systems need to evolve to reflect the needs rather than what we've thought we've needed in the past. And we really do need to become experts on blood coagulation. COVID-19 has recently emphasized that to us again in detail. We know that some people die from clots. These are the people with thromboses. We know that some people die with no clots. These are the people who bleed to death. And we know that some people die because we make them clot or we make them not clot inappropriately. And that's been something we've really not had a big lead on until the last decade. And we need to get better at that. Others have spoken about AI and machine learning, and I asked the question, why are we continuing to devote staff resources to read chest x-rays in 2021, certainly not in 2031, when AI can do it better than us, quicker than us, cheaper than us, and with more accuracy? Those doctors should be looking at patients, not at images. And we need support from the right people. I've been advocating for at least 20 years that we should have emergency department pharmacists. And other countries have done it, Australia, New Zealand. We absolutely need that in Hong Kong with our population. Pharmacology is our friend, but it's also our biggest enemy. And pharmacists have been shown to make a difference in other systems. And our physios and other allied health professional friends just make such a huge positive impact on direct patient care. They need to be more involved at the earliest stages of care. Digital health is the way forward. And again, we've seen in the presentations this morning, the excellent presentations this morning, how AI and linking things up and the Internet of Things can drive things like infectious disease diagnoses, cardiac arrest care, trauma care. We've seen recent technology looking at indwelling and transcutaneous sensors to look at sepsis diagnosis, microbiome changes. We've got to start looking at these things to try and speed up our diagnosis. And I think machine learning is part of that. We have incredible skills and capacity in computing that could help us to hit with things like antibiotic stewardship as well. So we need a vision for the emergency department of the future. We need to focus, and that focus needs to be on patient care. Patients are the heart of what we do, and that's what we need to focus on. So I'll stop now and say things are going to change. Just like they changed before, things are going to change again. 2031 will be very different to 2021. But we have a responsibility to shape those differences, not just for our patients, but also for ourselves and our colleagues, so that we can continue to serve those patients well. And innovation and new approaches will be the key to managing this, because we certainly won't have more people. I'll stop there and hand back to Kevin.
So thank you, Colin, for the very nice summary and actually a very good introduction to the talks that follows. Colin talked about the importance of flow, the innovations in trauma and radiology, and also mental health. So I think in the interest of time, maybe we'll defer any questions to later on. So let's have a 10-minute break, and we can come back at 11:30 for the next session.